So today I'm going to present a case on hemiplegia. Shall I start with the history?
You have done the examination, you can start with the diagnosis.
Okay, sir. So my diagnosis is right hemiplegia with upper motor neuron facial palsy, right side, motor aphasia, anatomical localization of lesion is at left internal capsule, possibility is due to ischemic stroke due to thrombus.
Okay, next.
11-year-old male child first born to a non-consanguineous couple has been brought by his mother, reliability fair with complaints of paucity in the movements involving right upper limb and lower limb, along with inability to talk on waking up one morning. There is some drooling of saliva from the right side of mouth while feeding. The child appears to understand what's being said to him, obeys commands, but he can't talk. Mother volunteers a history that he dropped and broke glass while trying to pick up a glass of water the previous evening, for which mother beat him on the right arm. She wonders if this initiated the present problem. No fever.
All the histories and why you are asking the history.
So no fever, no headache.
No, why no fever? Why you mentioned no fever?
So in the case of infection, inflammation, there may be fever. Like in the case of meningitis, acute demyelinating encephalomyelitis. Right. No headache.
Okay.
That is in the case of increased intracranial tension. In Cushing triad, there will be increased systemic blood pressure, decreased pulse, and irregular respiration.
Yeah, increased intracranial tension is more likely in a hemorrhage rather than thrombosis. Okay.
No head or spine trauma.
Why are you specifying spine?
Sir, an upper motor neuron lesion, there will be full facial palsy, so we have to rule out.
So if face is spared, it could be a cervical spine.
Yes.
Okay.
No nausea, vomiting, diarrhea.
Actually, intracranial tension causing vomiting is generally without nausea, retching and all. It just comes out of the blue.
Okay.
So nausea is less likely if it is a CNS problem.
Okay.
And regarding diarrhea, diarrhea in a small child can produce cerebral venous sinus thrombosis.
Okay, sir.
Where rather than this hemiplegia, there will be increased intracranial tension because this venous sinus means it is venous return. So venous return is blocked. So lot of backlog comes. So the tension increases.
Okay.
So that increased tension will produce increased intracranial tension.
Okay.
And so generally presents with decreased sensorium, seizures, etc. rather than any localized finding.
Okay.
And apart from diarrhea, this cerebral venous sinus thrombosis is possible with infection of the face, ear. Okay. So you have to possibly look for those things. And in adults, on estrogen treatment or chemotherapy can also be one of the reasons. But here it is not important. And in adult, of course, the antiphospholipid antibody also. And the diagnosis is not easy. You won't find anything in MR, so MR venogram may be needed.
Okay.
So basically it is severe headache, seizures, rather than hemiplegia.
No visual disturbances, no incontinence, no history of altered sensorium, behavioral abnormalities, no seizures, no sensory complaints.
So okay, this altered sensorium and behavioral abnormality, that indicates cortical involvement.
Cortical involvement.
And seizures, what did you say?
No seizures in this case.
Okay. And there is something
no
like
sensory
mother sleeping or what is that?
So mother sleeping with the child has not noticed any
Okay, that is very
sounds.
good. Because generally people mention no seizure.
Yes.
But you have said mother has not noticed, which means whatever pathology was there was on evolution during night time.
Yeah.
So if at all seizure is there, that must be at night. So you have specifically asked for that is very good. And sensory complaints are not there. Okay. Fine.
Not on any medication before this event.
Which medication, for example?
Anticoagulants.
Okay. And
so no bleeding to suggest coagulation.
And illicit drugs also can be.
Okay, sir. Illicit drugs. No bleeding to suggest coagulation disorders. No history of bone pain or purpura. So we can rule out leukemia. No history of joint pain, rash, oral ulcer. Connective tissue disorders unlikely. No history suggestive of viral exanthems, and no history of recent vaccination, which can be there in post-demyelination.
Demyelination.
No contact with tuberculosis, that we can rule out TB meningitis.
Yeah, because TB meningitis can cause thick exudate and strangulate vessels and cause.
So the flow will be slow. So general examination. Here we are only mentioning the relevant ones in this case. No neurocutaneous markers.
Okay, like Starr-Weber. Okay, you can pass next.
Head to foot examination.
Okay, there is nothing much there, but you have specifically look for dysmorphism, possibly something like Marfan, because you have looked for the upper limb, lower limb ratio also, because Marfan can cause dissection, or if it is homocystinuria, it is prone for stroke. Okay, and regarding the weight, actually that is interesting because weight is much more than expected.
Yeah.
But the height is normal. So that means it is not because of food intake.
Okay.
It is not exogenous obesity. So generally when this comes, we think of endocrine like hypothyroidism.
Okay.
So maybe totally unrelated to your hemiplegia, but we'll have to look for it. Okay. Next slide.
So next is about
Okay, that is nice. You have specifically looked for atrial fibrillation, because that is something that can cause embolism. Yeah. And you have looked for carotid bruit, very good, because the flow, if it is decreased in the carotid, it can produce this. So. And the BP.
Here in this case, BP is high. So.
BP is on the higher side for a 10-year-old child, correct. But whether this BP is the cause of stroke, difficult to say, because heroic measures to reduce BP at this stage is not correct, because suppose it is a thrombosis as we have diagnosed. In that case, it could be a reactive hypertension, which means the body is trying to supply the areas where there is no supply. So if we reduce the BP now, what's going to happen is the area of the so-called penumbra, that is partially perfused area, may be totally deprived of perfusion, because the perfusion pressure comes down. So in that case, it is not ideal. And then BP causing neurological is another one called Presno, the posterior reversible encephalopathy syndrome. But then generally it is not really the hemiplegia type. And yeah, one more thing, in such cases we should take the BP of lower limb also. It could be coact. So maybe only the upper limb BP is elevated. And in the meantime, if it is a hemorrhagic stroke, you actually will have to reduce the BP. So we need a CT.
Okay. So next is about examination of CNS. Higher function.
Okay, only the problem is speech, aphasia.
Aphasia.
The problem with your aphasia is you have localized it to internal capsule.
Yes, sir.
And speech is a cortical function.
Yes, sir.
So if it is aphasia, then it is difficult to localize to internal capsule, and also otherwise we will have to say there are two lesions, one in the cortex and one. So it is better that better to see whether we can fit in with dysarthria.
Okay, sir.
For example, cranial nerve involvement.
Okay, sir. 11-year-old male child was born to a non-consanguineous couple, has been brought by his mother with complaints of paucity in the movements involving right upper limb, lower limb, along with inability to talk on waking up one morning.
Okay, is it going with your diagnosis of thrombosis? You are sleeping normally and waking up without,
Yes, sir.
Why?
There
Why
will
is it
be,
so?
in the case of abnormal vessels, there will be a lodging of thrombus, and it can lead to circulation will be slow.
So you can have a thrombus. That's a good explanation, but of course the typical postgraduate explanation would be tissue plasminogen inhibitor has got a circadian rhythm, so it comes down, and so you are more likely to have a thrombus early morning. But this is a very reasonable explanation. And regarding your motor aphasia again, motor aphasia specifically you say that he is understanding all the commands. So
Yes, sir.
it is a very localized Broca's aphasia,
Okay.
which is actually localizing it to cortex. That is actually difficult because you have already localized it to
Internal
capsule. So, and also if it is localized to the cortex, the Wernicke also may be affected. So,
Okay.
the understanding can also go unless it is a very localized Broca's alone.
Okay.
So, in this case, we should try to fit in all the findings to our diagnosis. So, in that case, we can fix the diagnosis as somewhere in the subcortex. Not that the internal capsule is not subcortex, it is also a subcortical structure, but somewhere between the cortex and the internal capsule, we may be able to explain that aphasia.
Okay.
Or we should think whether it can be fitted with a diagnosis of dysarthria or dysphasia, dysarthria.
Mother volunteers a history that he dropped and broke glass while trying to pick up a glass of water the previous
So, what
evening.
could be the reason for that?
Distal muscles are weaker, sir. So the stroke may be started at that time.
Okay, so what do you call that?
Transient ischemic attack.
Okay, transient ischemic attack. What is the general natural history? Normally, it will progress to a stroke, within, say, a few hours or maybe a week, maybe 1 to 3 months. But it will definitely progress.
Progress
So
to stroke.
we must pick it up at that point of time and intervene. So transient ischemic attack can present in various ways, like neurological deficit like monoplegia or difficulty to speak, some visual disturbance and so on. So this very well fits in with the transient ischemic attack, but in this particular case it was possibly the thrombus in evolution.
Yes.
So thrombus was forming in the evening itself. It
And it
just
progressed.
progress, and by the next day morning the vessel completely got blocked.
Okay. So next is cranial nerve examination. Olfactory nerve. Child is able to discriminate between different smells such as soap and chocolate.
Okay, that is also a nice way of doing it, because this is not the standard method of examining, but we should give articles with which the child is familiar with. Otherwise, you will not be able to know whether the child is able to discriminate or not. So, soap and chocolate is a good thing, and fundus, of course, for papilledema we must look for. And of course, if it is not visualized, it's okay.
Oculomotor, trochlear and abducens nerve.
The only thing is your jaw jerk is not exaggerated, but you actually may not get an exaggerated jaw jerk. For an exaggerated jaw jerk, you need something like a pseudobulbar palsy, where bilateral cortical involvement, not unilateral. Okay.
Facial nerve.
Yeah, facial nerve is UMN according to you.
UMN type of facial palsy.
Yeah, can you have a LMN facial palsy and hemiplegia?
So that might be then crossed hemiplegia.
Yes.
And the
Because hemiplegia will be in the opposite side of
Opposite side.
cranial nerve involvement, because cranial nerve is involved either in the nucleus or the nerve. So for the nucleus to be involved, it should be pons or maybe lower down.
Lower pons lesion. Then comes the vestibular cochlear nerve.
Tinnitus basically is a peripheral phenomenon, not really a central phenomenon. And it's good that you have not tested gag reflex, because it is not adding any additional information, but at the same time it will make the child uncooperative. Because there is no difficulty in swallowing, no nasal regurgitation, so very unlikely to have that nerve involvement. And hypoglossal nerve, naturally you should look for, because you are looking for a dysarthria as a diagnosis, because your aphasia is not fitting in with your localization. Okay. And actually those things are also, for example, facial nerve itself can produce some speech disturbance, so that can possibly explain part of it. For example, labials, pa, ba, something that is involving the lip, that will be difficult with the facial nerve involvement. But the other thing, for example, the ninth nerve is something that involves the palate, ga, etc. And the 12th nerve is involved in the tongue. So ta, da, something that the tongue is going into the palate. So it's very good that these nerves are examined.
Next is motor
Bulk is, of course, bulk difference we generally get in a congenital hemiplegia. Acquired hemiplegia is just overnight, so we will not get a difference in bulk.
Power, distal muscles are weaker.
Yeah, that is obvious. All the distal muscles are weaker as compared to the proximal muscles. And proximal muscles are reasonably strong. 4. Okay.
Yeah. Then reflexes, superficial reflex.
Abdominal reflex absent is expected in acquired hemiplegia.
Okay.
And cremasteric not allowing exam, that is fine. He's an adolescent boy and we are not going to get any additional information by cremasteric reflex. Regarding the clonus, of course, there is clonus, and the area from which clonus can be elicited is also increased, and there is an adductor spread. Okay.
Sensory system is intact, sir.
Yeah, the most important thing is we must look for the cortical sensation, because we are localizing it to internal capsule, but still because of aphasia we are having cortex in our back of our mind. So cortical sensation is.
So cerebellar function test I don't rely, as the power is 2 by 5.
Yes, you need a power of 4 or 5 to have a.
Then cardiovascular system, first and second
have a systolic murmur.
Systolic murmur at apex.
That is a typical MVP murmur, but that we have already discussed in another video, so we will not discuss it here.
Respiratory system, normal vesicular breath sounds heard bilaterally, no added sound. Per abdomen, soft, no organomegaly.
And although you said there is no seizure, there was one mention of a twisting movement, right?
Yes.
So, how will you explain that? See, most probably, again, since we have localized it to internal capsule, that twisting movement is less likely to be seizure, because you are not localizing it to cortex. And you have specifically mentioned, like, what is that? There is no loss of consciousness, no incontinence. So that means it is less likely to be seizure. So basal ganglia region is very near your internal capsule. So maybe one of the perforating branches involved, that is more likely rather than considering it as a seizure. And then the gait we have not mentioned. The gait actually, if the child can walk, then the typical hemiplegic gait will be there. And in addition, the associated movement, the movement of the hand along with your walking, that may be lacking. Now, suppose there is a deterioration after admission, what could be the reason? The deterioration is generally, deterioration means sensorium is coming down, new signs are appearing. So it could be because of, so differential diagnosis.
Hemiplegia migraine, post-ictal toad palsy.
Hemiplegia migraine means you must have a family history or a personal history of previous migraine or headache. Okay.
Then post-ictal
toad's palsy, which is a very transient, 124-48 hours. So, any other?
Hypoglycemia.
Hypoglycemia, yes, can present as a neurological presentation. Can rarely present as hemiplegia also. Then meningitis, of course. But meningitis generally is not as a hemiplegia. Multiple, for example, cranial nerve palsies. So that is more likely. But still, meningitis, especially tuberculous meningitis, you can very well have hemiplegia. Then it could be a intracranial space occupying lesion,
like brain abscess.
Brain abscess, yes. And there is something called metabolic stroke, where the respiratory chain is involved, and you can have, for example, MELAS, metabolic, encephalopathy, mitochondrial encephalopathy, lactic acidosis, and stroke. So, in such cases, we can, in investigation, we can have a look at lactate and CSF and serum. What other investigations will you do?
So we can do CT,
MRI if you want, and coagulation profile, and especially peripheral smear for sickling, because that can cause block. Then rarely protein CS, etc. But extremely unlikely. Then, yeah, that is more or less the investigation. Then, regarding treatment, the thrombolysis is basically in adults. I have not seen thrombolysis being done in a child, although theoretically you can do thrombolysis. But in child, thrombosis is less likely. It is more likely it is embolism and hemorrhage. So 1/3 will be thrombosis, 1/3 will be embolism, or 1/3 will be hemorrhage. Like adults, you can't go on for thrombolysis. But in approved thrombosis, definitely you can go for thrombolysis. Only thing is, I have no experience. I have not seen it being done in places where I have worked.
Okay, sir. The causes of young stroke may be due to subarachnoid hemorrhage, thrombophilia, any demyelinating disease, homocystinemia.
Subarachnoid hemorrhage generally is severe, intense headache rather than hemiplegia or stroke.
Okay.
Okay, the other? Okay.
Other causes.
And there's metabolic mitochondrial encephalopathy, yes, that is also.
Polycythemia.
Yes. Polycythemia becomes a cause in a small
Yes.
child, like infants.